So I think in the last years we really have made a lot of progress in our understanding of the molecular biology of HCC. Specifically with the help of next generation sequencing, we were able to identify a lot of mutations which we can frequently observe in hepatocellular carcinoma. However, these findings have so far not really translated in a really targeted therapy or successful clinical trials in HCC because there are a couple of problems. First of all, we have a really significant intertumoral heterogeneity, which means we do not have one single driver mutation which would be important for all tumors. And also, if you look at the genomic alteration we can find in HCC, there are some mutations, for example, mutations in p53, which we can find quite often. If they occur in patients with an hepatitis B underlying liver disease, with the viral hepatitis B infection, it can have prognostic impact. So it's a poor prognostic markers. And it's not in patients who do not have a hepatitis B infection, which means specific mutations can have specific or different meanings in the context of the underlying liver disease. And the other problem we have is that we also see within one patient different tumors. So we have an intertumoral heterogeneity, which makes it also a little bit more complex. So we have improved our understanding in the molecular landscape of hepatocellular carcinomas. We have identified early mutations like mutations in the third promoter. We know what are the most frequent mutations in beta-catenin, for example, p53. But so far, we were not able to use this to really improve our treatments we have at the moment. So I think first of all, we really have to distinguish different groups of patients we see in our daily clinical life. So some patients have really early disease, which means they have one single nodule, they're candidates for liver transplantation, for example. Then we have patients with intermediate stage disease that means they have more tumor nodules, larger tumor nodules. And we have patients with advanced disease, which means they have vascular invasion, for example, or extrahepatic metastases. And for all these different stages, early, intermediate, and advanced, we have different treatment options. And another point which is really important in the treatment of HCC is that these patients do not have one disease, they have at least two diseases, because they have the underlying liver disease, which means they have a chronic infection, for example, they might have liver cirrhosis, which also might impact on the treatment we can use in our patients. And most studies we have were done in patients with very good liver function, which makes it also very difficult, which brings me to your second part of your question. Is the treatment of HCC very individualized? And I think it is. It was always, because it has to be, specifically because we have two diseases, the chronic liver disease and the tumor. And both needs to be acknowledged and balanced, and we have to find for every patient the best possible treatment, which depends on both.
Hepatocellular carcinoma, or liver cancer, is a very complex disease. Unlike a lot of malignancies we treat, it almost always, 90% of the time, occurs in the presence of underlying liver disease, some degree of cirrhosis. The most common causes being hepatitis C, hepatitis B, alcohol use, and now increasingly the metabolic syndrome and non-alcoholic steatohepatitis. Because of these two diseases, there's a competing risk for outcomes, that is, outcomes from liver disease and outcomes from a malignancy. And therefore, its approach really requires what we term a multidisciplinary team. The only way to cure the disease is really with a surgical approach, which means resection or transplant. For disease confined to the liver, interventional radiology plays a very key role with procedures like radiofrequency ablation or chemoembolization. Hepatology is often involved because of the underlying liver disease and complications that arise from that. And then people like myself, medical oncologists, who help triage patients through the system as far as appropriate care for their given stage, as well as managing generally patients who have advanced disease that need systemic treatment.